Welcome, everyone. Thanks for joining us today. We'll get started in a few minutes.
Yes, welcome everyone. Yeah, so welcome everyone. I think we should be good to go. We have a lot of people that are still coming in, but I think we have enough people for us to really start, since our meeting time is very time sensitive. So yeah. So I'm Kamara McIntosh, and I'm a program specialist here at the Department of Health and Mental Hygiene for suicide prevention initiatives. And again, welcome to our the first part of our webinar series. Yeah, so I'm just going to go through a couple of slides, as a part of our intro. So next slide. So on today's agenda, we'll be framing the webinars within the broader context of the NYC Department of Health. And we'll have presenter introductions, and then after that, housekeeping, and then we'll have the presentation. Next slide, please. So the NYC Health Department aims to reduce suicide deaths and suicide-related behaviors among New Yorkers, with a focus on youth of color. To achieve this aim, NYC's Health Department will provide enhanced monitoring of suicide as an urgent public health issue, increase and diversify suicide prevention services for youth, and their support networks, expand efforts to mitigate their socio-environmental risk factors for suicide through interdisciplinary strategies. Next slide, please. The NYC Health Department youth suicide prevention initiatives are being executed through interdisciplinary partnerships with community-based organizations, researchers, designers, and medical institutions across New York City. Some of these new services include innovative suicide prevention pilots that serve youth and young adults of color. We have our Care in Transitions, which is a collaboration between the Health Department, Health and Hospitals, and the Mayor's Office of Equity to reduce suicide-related readmissions to emergency departments for youth in Queens and the Bronx, ages 5 to 24. Right, and the Department of Health is also investing in action-oriented research and capacity building efforts intended to raise awareness about suicide risk and protective factors for New York City's BIPOC youth. This is why we're hosting a series of 4 webinars over the next several months dedicated to this topic. And now I'm going to pass it over to, next slide, please. I'm gonna pass it over to my colleague, Claire.
Thanks, Kamar. Good afternoon, everyone. My name is Claire Ogburn, and I'm the Data and Program Coordinator for Suicide Prevention Initiatives at the New York City Department of Health. I'm excited to introduce you today to today's presenters. Next slide, please. So Dr. Erica Bath is a child and adolescent, adult, and forensic psychiatrist. Dr. Bath is a professor and vice chair for Justice, Equity, Diversity, and Inclusion in the Department of Psychiatry at the UCLA David Geffen School of Medicine. And she's a senior advisor for the UCLA School of Medicine's Anti-Racism Roadmap. Dr. Bath has a long-standing interest in community mental health and has committed her career to advancing health equity for ethno-racially minoritized and structurally marginalized youth and families, with a specialized focus on youth impacted by the foster care and juvenile legal systems. Thank you for joining us today, Dr. Bath. Next slide, please. Yes. Our second presenter is Dr. Jocelyn Meza. Dr. Meza is a bilingual psychologist. She's assistant professor in residence in the Department of Psychiatry and Biobehavioral Sciences at UCLA, and she is the associate director of the Youth Stress and Mood Program and the principal investigator of the Health Equity and Access Research and Treatment Lab, both at UCLA. Her research and work aim to integrate psychological, cognitive, and socio-cultural influences to predict suicide and self-harm behaviors, and importantly, to identify therapeutic targets for culturally responsive interventions for youth of color. Thank you for joining us, Dr. Meza. Next, I'll briefly go over some housekeeping items. So this presentation is the first of a 4-part series. The webinars will build upon one another, but you don't have to attend all 4. You can gain a lot by attending any number of the presentations. And in the next 3 webinars, Drs. Bath and Meza will be joined by Drs. Aaron Godfrey and Shabnam Javdani, who are subject matter experts from NYU. And you may have noticed that they're here today as well, supporting the webinar and in the chat function. This webinar is recorded and we'll be sending the recording to all registrants after the presentation ends. Our presenters have done their best to use sensitive language in this presentation, but this topic is tough and could be triggering for some people. So we will share resources about 988, the Suicide and Crisis Hotline, with you in the chat and via email after the webinar ends. It's the country's new easy to access 3-digit dial and texting code to get help in a suicidal or emotional crisis. It's also here on this slide. If you need additional resources, you can reach out in the chat and we can help you via that way. Next, you can submit any questions you have for the presenters using the Q&A function, and we'll do our best to get to all the questions at the end of the presentation. And any that we don't get to, we will cover via email afterwards. If you have any tech issues, you can try to address those in the chat. And then I'll also put my email and Dr. Godfrey's email in the chat as well. So you all have those if you need to reach out in case of a tech issue. And finally, at the very end, we're going to be sending a quick survey for you to share your thoughts about this presentation with us. And we hope that you'll fill it out because it will help us take your feedback into account for the next 3 webinars. So that's all for housekeeping. So I will stop sharing my screen and I'll turn it over to Dr. Bath to begin the presentation.
Thank you, Claire. It still says disabled. Let's see. Still says disabled. Let me try again. There we go. Let's see, I need to do swap displays. Now, can everyone see you need to see a different version of this. Okay. Are we good?
Yep, that's perfect.
Great. I'm just going to fast forward some of these slides that we already went over. Okay. Great. Reduce this. Okay. I am pleased to speak to you all today about racism and discrimination and the impact on youth suicide. And I'm using the purple and teal colors because those are commonly associated with suicide awareness and prevention. Before we get started, I'd like to do a land grant acknowledgement. I am a faculty member at UCLA, and we are on the unheeded ancestral lands of the Gabrielino and Tongva First Nation people. And land grant acknowledgements are really stepping stones to honoring broken treaty relationship. And so it's important to really be anchored in paying respect. My disclosures in terms of places where I've received funding for, but I really have no conflicts of interest. And what I like to do is with my talks really reflect on my own positionality. And so this wheel is the intersecting axes of power, privilege, and oppression. And really what I like to do is think about the ways in which my various identities impact my work. So I identify with she, her pronouns as a Black cisgender heterosexual woman. I'm an African descendant of enslavement with Caribbean roots. I'm a granddaughter of domestic worker and merchant seaman and mother to a teen daughter. I'm a second generation physician, a Black physician activist. I've worked predominantly in white institutions my whole career in academic medicine, but also simultaneously in the juvenile legal and child welfare system. I'm an HBCU medical grad, an inspiring good trouble champion. And I think it's important for you to understand really what I'm bringing to the work and what my past and how that informs my lens. So the goals today, we're going to understand really what is racism, why it matters for health and mental health and suicide in particular, structural racism, really understanding how racism is a public health crisis, the impact on behavioral health and suicide, and also develop some fluency and familiarity with relevant theoretical frameworks to contextualize discrimination's impact on behavioral health. And we really thought it was critical to start with this understanding just to set the foundation as we explore the inequities in BIPOC youth suicide, because racism and structural racism really is at the one of the most potent and pernicious drivers of inequitable suicide outcomes. I really love this quote from the late Dr. Martin Luther King, but talks really about inequity, inequality, and that injustice in healthcare is the most shocking and inhumane. And I think that that's one of the calls to be here today, is to really start to address some of the inequities that we see in health. And what I like to do in terms of situating this conversation around racism is to anchor us in looking at the Sankofa bird. Now, this is a Ghanaian symbol, and it really encourages us to reject a historical framing. And so we can't really talk about BIPOC youth suicide and eliminating inequities or addressing well-being for this population if we don't talk about racism, right? And so we need to look to the past so that can inform our present. So we are going to be in the here and now, but the legacy of historical trauma of racism is relevant in understanding how systems have been shaped and what we need to do to eradicate inequity. Again, James Baldwin, people are trapped in history and history is trapped in them. So setting foundations and guiding principles. So what is race and what is racism? There's no such thing as race. It's important that everyone recognizes that racism is a social construct with the social function of racism. So really, there's no such thing as race at all. It was really designed for the function of racism, and that our DNA is 99% the same as the person sitting next to us. And really understanding that race has been manufactured and is a really modern idea. It's not based in biological or scientific fact, and really has been used, really as a pseudoscience to classify different groups to really legitimize dominance and power. And so no one was white before he or she came to America, and it took lots of generations and coercion before this became a white country. And even the definition of whiteness has changed over the past several hundred years, with certain groups being included as white and then eliminated from being included as white, depending on economic interests, our global participation in wars, etc. So it's really important to recognize that race is really a social construct which helps support and uphold racism. And so what is racism? It's really, I like to use the definition from Dr. Kamara Jones, who was the former president of the American Association for Public Health, also at the CDC, but she really describes it well as it's a system that unfairly disadvantages some individuals and communities and unfairly advantages other individuals. So understanding that there's structural advantage and disadvantage, and really it saps the strength of our whole society through the waste of human resources. And understanding it as a system is looking at it through these different lenses, right? So the impacts of racism are broad and far-reaching and impact housing, education, employment, criminal legal system, and healthcare. And these are just some of the systems, but if you really think about the sequelae of racism and policies that uphold it systemically, there's negative impacts across these different systems. And we see this when we talk about zip codes determining health outcomes, in terms of redlining, in terms of differential profiling systems. And all of these have potent impacts on mental health. So systemic racism really refers to a system where public policies, institutional practices, cultural representations reinforce ways to perpetuate racial group inequity, and it really reflects historically accumulated white privilege, national values to preserve the gaps between white Americans and Americans of color. Ta-Nehisi Coates, he's one of my favorite authors, and I thought that this quote was so telling to really sort of drive home the fact of racism as a social construct, race as a social construct, but that race is the child of racism, not the father. So many people mistakenly assume that race happened first, but racism happened first. And so some of the relevant theoretical frameworks, just to anchor our journey in understanding BIPOC youth suicide, really are these, and I'll go over them briefly. So intersectionality, which may be familiar, I hope, to most folks, public health critical race praxis, racism as root cause, structural competency, and structural intersectionality. So intersectionality really refers to it was coined by the legal professor, a scholar, Kimberly Crenshaw, but it was really to highlight the ways in which people often have multiple identities and multiple identities that may be of marginalized status. And so similar to the positionality statement that I included in the beginning, it's really important to think about how people are subject to multiple forms of social and personal identities. And so as Audre Lorde says, there's no such thing as a single issue struggle because we do not live single issue lives. So many people's identities are a confluence of different factors. And so as we think about how and why we have inequities in BIPOC youth suicide, their identities are often intersexual in nature and often have multiple marginalized identities, and so experience oppression and health inequity at a greater level. Public health critical race praxis is another way of conceptualizing health, and really sort of what has us think about the sort of contemporaneous current events and how those also play a role in terms of health outcomes, and also who are the people who are endowed with being in charge of producing knowledge. So understanding that knowledge is a social construct and really trying to shift and towards more marginalized groups to have them participate in the knowledge generating practice. Also understanding that race is a social construct, the theme of intersectionality, and then, what are the sort of critical approaches that we're going to use in an action-oriented zone to lift up and change health and equity. So really to address health inequity, we need to think about the primacy of contemporary patterns of racial relations. So yes, it's important to think about the legacies of enslavement and Jim Crow, but also recent issues like COVID-19, the murders of George Floyd and many others in police brutality. Those contemporary patterns really are also part of how we need to think about health. Then also thinking about knowledge production, conceptualization and measurement. How do we sort of think about our data systems, right? And are we thinking about them in an intersectional way? And then once we do that, how are we disseminating the information to whom and who are at the table? Racism at root cause is another concept that I think is really a key, and it's really recognizing racism as an upstream driver of negative health outcomes. And so how do you know if racism is at the root cause of any of the health inequities that you're seeking to address, and if this population is affected? So if you can answer yes to any of these questions, so barriers to wealth accumulation, educational inequities, housing insecurity, disparate treatment in the legal carceral system, and disparities by skin or tone. If you can answer yes for someone you're working with, that means racism may be at the root cause. The concept of structural competency was developed by doctors Helena Hansen and Jonathan Metzl, and it was really to get us as clinical providers to think extra clinically. So health and well-being is not just happening in the clinical setting, right? And so we need to develop that extra clinical language and leverage our positionality to work on structures, right? So much of health outcomes happen up here. If we're just in the room here working on the disparities, but we're not leveraging our power and our privilege to actually address policies, practices, procedures, and programs, and also have racism be addressed more robustly, then we're not going to make as many inroads. So it's really important to actually develop extra clinical language that understands structures and sees how structures shape health outcomes. Because there's a tendency to focus on people's behavior and the behavior as being the problem. But if we don't sort of situate people within their communities and communities that are structured by economic disadvantage and racism, we won't have the type of empathy that we need to advance their well-being. Structural intersectionality is a newish concept for me, but I find it really inspiring because it really sort of mashes up Kimberly Crenshaw's themes of intersectionalism with Jonathan Metzl and Helena Hansen's work. And really, we need to think about how structures, right, the education, mental health, juvenile legal system, all these structures that have forms of oppression often overlap. And the people who are overrepresented in the most marginalized settings are those who have more intersectional identities. So it's really sort of thinking about intersectionalism across structures and how there's structural vulnerability by these systems. So this is another way of thinking about it in terms of the macro structures and policies, right? So the child welfare system, immigration system, legal system, and how these policies come down hardest on people who have multiple marginalized identities, and recognizing that racism and historical trauma are a potential lens. So I have a short video. I'm hoping that it is optimized, but I wanted to sort of have people be anchored in the historical and understand the history.
Dr. Bath, the audio is not being shared. I think you're gonna have to reshare and then click on the bottom where it says share audio.
Okay, let me. Okay, sorry about that, everyone. Oh, there we go. For some reason, it's not letting me click on that. Do you see? It's like it's not letting me do that. Oh, let me see, advance. Let's see. Maybe I will skip the video because it's not allowing me to do the optimization, like the click is not happening.
Dr. Bath, no worries. Share your screen again, and just share your slideshow on that slide,
Okay,
because we can't see your slides anymore.
okay. One second.
And it might work now. If
Okay.
you retry.
Okay. Yes or no?
No sound.
No sound. Well, the sound for this isn't as important because it's just cheesy music, but the images are important in terms of really showing the legacy of legislation over the chronology of years. Now, I know we have a lot of folks, but we do have a chat, right? So what did people see in that video in terms of just the chronology of events, right? Because there are a lot of dates shown. Did people notice anything specific? And can I see everyone's chat? Let's see. Let's see, new messages. Okay. Yes, accumulation of wealth. Opportunity lack to accumulate wealth, equity disparity, right? Well, and I think it's important to see how long that gap has persisted, right? How long it took for them to start, really. And we didn't really, a lot of folks didn't get started in 1964, right? Just because there was like voting rights. That's still like, look where we are today, right? So the sort of legacy and historic events. Thank you, chat participants. Thank you. Yes, and you can keep going to the chat. And so really thinking about racism, right, across the lifespan, potentiating the development of adverse childhood experiences, sort of generational embodiment, historical trauma, but it's something that's operative from wound to tomb. And so we need to sort of be anchored in the historical, i.e. Sankofa bird, right, to understand its effects. And this is not just me talking about this, right? Racism is now and has been sort of recommended to be considered a public health threat. Most of the major medical and behavioral organizations are highlighting this. So this is just something from the American Medical Association back in 2020. This shows several cities around the country, jurisdictions really sort of making declarations that racism is a public health crisis. And really, you know, thinking about why we need to think about racism in this way is you can look at any of these systems and see the disproportionate effects and how that ends up resulting in health inequity. So whether it's how many kids, how many dollars are applied for a kid in a low performing, you know, Black school district versus a white school district, or differential sentencing patterns or greater odds of incarceration, financial crises, all of these areas have ongoing systemic base race inequities. Also, the AMA's statement, again, on why it's important to address racism. The National Institutes of Health actually apologized for structural racism in biomedical research and pledged millions of dollars to address it, not only from the research enterprise in terms of what sort of questions are going to be asked and what sort of studies, but also in terms of dealing with provider workforce. The CDC recognized this as a threat back in 2021. And I think what's important here is recognizing it as a system, right? Racism as a system, and that there's interpersonal and structural ways in which it harms individuals, right? And so that it is a key sort of structural determinant of the social determinants of health, and it leads to poor health outcomes. This is the American Psychiatric Association, and I'm shocked and awing you with all of these organizations just so that people recognize that really it is part of the current zeitgeist, at least the performative aspect of these statements, right? To actually recognize, and I think, you know, I've been a physician since 1999, never have I been able to talk about racism with so much fluency and have so many different organizations also center it. So I feel like the time is now for us to really be able to make these type of inroads. And so why is it important to learn about racism as a structural driver? Well, racism costs a lot of money. And it's estimated that our economy lost $16 trillion because of discrimination, right? And so Heather McGhee's book, if you haven't read it, it's called The Sum of Us, but she talks about what racism costs everyone. And it's not only like thinking about it in terms of health inequities and the public health harms, right? But just in terms of economic success. So it is very far reaching. This slide from my colleague, Dr. Heath Norris, talks about if we were to eliminate racialized health disparities, what would things look like and how much money we would save. And so it's a $230 billion projected economic gain per year if health disparities alone were eliminated. For Blacks, there'd be 220 fewer deaths per day. That's 80,000 deaths per year. So there really is a key need to sort of think about this, and also its touch points with suicide. Okay, so hopefully you believe now racism is bad for your health. And these are just some of the, I think, by Ruth Shin and Sarah Vinson, psychiatric colleagues who talked about sort of health injustice and thinking about them. And so things that I want us to reject and to consider are the essentialism, right? So the belief that there are distinct, unchanging, and natural characteristics that define social groups. So we must reject this, right? Because this is really sort of the old thinking of race as a biological construct where, you know, certain in-group characteristics are, you know, fine-tuned and that's the way they are. And that's not true, right? We have to recognize the structures. Also, this belief of, you know, false belief that racial groups are biologically and genetically different. Erasure of context. So this is failure to consider the socio-historical context and structural drivers, and also cultural determinism, the false belief that differences in racial groups are primarily the result of cultural factors. I like this slide because it talks about and situates structural discrimination, right, as a driver for laws, policies, procedures, practices, exerting forces on these systems that impact health and well-being. And it's not just racism, right? So I'm focused mostly on racism on this talk, but I'm using it as an umbrella also to talk about other forms of discrimination that are as pernicious, that often coexist, thinking about structural intersectionism. And these all interact across system domains to have negative health outcomes. So let's talk a little bit about how racism is bad for your health, right? So we talked about structural racism and its impact on populations and different structures, right? But people are living in those structures. And so it's important to recognize that racism has negative effects on health, not only on structural environments, personal environments, but really at the physiological level. So this study by Arlene Geronimus actually looked at the interplay between racism and something called allostatic load scores, and found that Black individuals had early deterioration of their health and advanced aging, right? Because those who were experiencing more high effort coping with everyday discrimination, their telomeres were shorter, and telomere length is a function of your age, right? And so in some, I believe it was like, maybe 7 years older, right? And we already have lower life expectancies, and particularly depending on our zip codes, right? So this was really sort of revolutionary. And so it's called the weathering hypothesis, but that weathering is happening due to discrimination, and it's happening at the microcellular level. Again, this is another slide that talks about allostatic load and the cumulative index of multi-biological aging, right? So getting stressed is normal, and our bodies are adapted to stress, right? We have neurotransmitters and hormones that are released in response to stress. And so we are able to adapt just because that's our biology. However, if you're constantly under threat, if you're constantly having to activate that stress pathway, which is a racialized phenomenon, that certain groups, ethno-racially minoritized groups, have more stress because they're walking while Black, jogging while Black, anti-API hate, anti-LGBTQ hate, all the sort of levels of hate crimes, which have actually been growing post-COVID. That high effort stress reaction that people are under really causes really our organs to break down. And so there have been studies that have found that this sort of constant wear and tear due to the hormones that are produced in overload that are normally necessary for survival has resulted in elevated allostatic load, which has actually correlated with wear and tear on body organs. So racism is bad for your health at the microcellular level, but it's also bad for your mental health. So more depression, anxiety, and psychological stress. This paper is a systematic review and meta-analysis that looked at several studies trying to examine the impacts of racism on health and just general health and mental health in particular. And one of the things I thought was really interesting was that racism and negative mental health was stronger for Asian American and Latino American participants compared to African American participants. And so you'll see different studies. I think the take home is racism is bad for everyone. And it's really thinking about Heather McGee's book, right, The Sum of Us, where it costs all of us, not only in terms of lost wages and capital, but health across populations. So racism can impact health via several recognized pathways, not only at the structural level, right, but at the physical level, physical injury, diminished participation in healthy behaviors. And so we're going to tease out some of these specific areas. Okay, so thinking about youth in particular, Black kids face racism even before they start school, right? And it is really associated with something called racism-based traumatic stress. And so this really refers to mental and emotional injury caused by encounters with racial bias. So just the anticipation of having a harm, right? And the experiences of the harm and the prolonged experience of these harm can lead to symptoms similar to post-traumatic stress disorder. And so racialized trauma can come either directly from people or experienced within a wider system. And racism-based traumatic stress comes as a direct result of where racism is enacted on you, or it can also happen vicariously. So the sort of omnipresence of negative images of, like, during after George Floyd was murdered, and the sort of relentless onslaught of video imaging, right? That's harmful for people's well-being. So not only at the individual level, right, but at the collective community level, and recognizing that that's just one type of harm, right? It's different than the sort of everyday discrimination that people may experience. And really having these sort of recurrent images and sort of racialized trauma is not good for your brain, right? And so as we saw with the allostatic load and the weathering hypothesis, that typical development, you are really trying to spend more of your time in this sort of blue, high functioning cognitive zone. But when you have a lot of traumatic events, and also lots of discrimination, it's felt that, developmental trauma has people spending more of their brain space in the survival zone. And then that is, emotionally taxing and puts people more at risk for negative health outcomes. So thinking about just discrimination and mental health for kids, really, discrimination really predicted worse mental health outcomes across the board and was inversely associated with positive mental health. And so I think that that's really important to think about, because as we want to address youth suicide, how are we working at root cause, right? One study of Black adolescents aged 10 to 12 assessed their exposure to discrimination 3 times over the 5 years and really found that increases in experiences, self-reported experiences of racial discrimination were associated with higher levels of conduct problems and depressive symptoms as well. Also, youth exist within their families, and parents' exposure matters, right? So if parents are getting exposed to discrimination, which they are because racism and discrimination are equal opportunity, unfortunately, these can adversely affect the child. So understanding sort of parental experiences, how that can, their perceptions and how that can lead to substance use in children, depression, and anxiety, and also poor maternal health. And so really the effect for racism to kind of have this sort of sticky residue across populations, across families, matters. In addition, thinking about just the individual level feelings, right? So when people have experiences of racism, they often feel over scrutinized, overlooked, underappreciated, and this sort of violates, it's this sense of moral injury. It violates their sense of dignity and sense of humanity. And so really this sort of direct attack on someone's identity, and we see how identity formation and having intact identity is really critical in thinking about suicide prevention. So let's talk a little bit about suicide. There is a crisis in youth suicide. It is leading cause of preventable death among youth in the US, and this is why we're here, right? And really it's something that has been increasing for ethno-racially minoritized groups, Native American, Alaska Native youth, Black and Latinx youth, with the highest suicide attempt rates in Latinx girls. And so there have been lots of different sort of ring the alarm outreach efforts to address this, like this conference, but it's really sort of critical to start thinking about the needs of different groups. And so if we look at data from the high school youth risk behavior survey, in terms of different populations who've been thinking about suicide, plan for suicide and the attempts, and looking at some of the trends, really looking at these Black and Latinx populations where our levels are. And historically, I think in my training, at least as a psychiatrist and a child and adolescent psychiatrist, I was never taught about structural racism in medical school or in residency, and nor was I taught to really think about structurally vulnerable populations and how they may have more risk. Suicide really was often billed as, I don't want to say like a white disease or problem per se, but any sort of exam question, it was always an older white guy with a gun, and never sort of thinking about the risk, right? The narrative of suicide has been racialized to be excluding of ethno-racially minoritized groups. And we know that the data is not true. So there's also this disconnect, right, to the actual true story. And so thinking about suicide across these different risk groups, and this actually should remind us of the previous slide of thinking about structural intersectionality and the different groups. But these groups, if we understand structural racism, right, and we know which groups are going to be overrepresented in certain systems, think about that story across these domains. So who's mostly present in the juvenile legal system? immigrant youth who are ethnoculturally vulnerable, sexual gender minority youth, child welfare systems, commercial sexual exploitation, youth who are unstably housed. So many of the youth who are overrepresented, and often in multiple of these categories, right, are ethno-racially minoritized youth and youth who have marginalized identities. I just want to highlight quickly American Indian, Alaska Native, Indigenous youth who've been having high rates of suicide for decades, right? And a lot of the inroads that we've made in suicide prevention have not really been culturally informed to really address the need of this population. So suicide is a leading cause of death among American Indian and Alaska Native youth ages 15 to 19. And we're just not really capturing in real time how to address both ideation and attempts in this population. In Asian American Pacific Islander youth, also very few studies report on self-injurious thoughts and behaviors for Asian American youth. And this is, again, our incomplete sort of way of addressing suicide cross-culturally, and really not even cross-culturally, but recognizing the sort of multi-ethnic society we live in, and thinking about suicide prevention from that lens. I'm going to, in the interest of time, just highlight that for Latinx and Black females, ages 15 to 24, they've had the greatest increase in suicide deaths, right? So not only suicide attempts, but rates of death by suicide, and that this, has been spotlit. Really, the point number 3, where Black youth ages 5 to 12 have a suicide rate that's roughly 2 times higher than white children, that got a lot of media attention, but some of that data wasn't new, right? And that was what was most shocking, and how long it took for certain professional organizations to name it. And then really there's still a gap in terms of addressing it and addressing some of the root causes. Okay, I'm going to move forward. Okay, so thinking about suicide attempts by race and ethnicity. So both of these are really critical surveys, and the Youth Risk Behavior Survey. And it's just, again, to draw attention to the epidemiology of suicide and where certain groups are falling in terms of reporting a suicide attempt in the last 12 months. Percentage of high schoolers also reporting attempt by these same data sets. And I think the alarm bell is like, look at the rates, right? The percentage of youth, also multi-ethnic youth, multiple racialized youth, and also just the overall prevalence, right? So it's almost 8% regardless of the youth population in these studies, and really just the crisis in particularly for American Indian, Alaskan Native youth. And also thinking about risk. So I started this talk sort of talking about structural racism, and but I wanted to sort of highlight all the isms and discrimination. And so we do see how intersectionality plays out, and discrimination is a big driver of suicidal risk and behavior. And so suicide risk is higher among LGBTQ youth than among their cisgender peers. And so during the pandemic, the percentage of LGBT youth reporting a suicide attempt in the last 12 months was actually 5 times greater than their heterosexual peers. And approximately 1 in 4 LGBT high school students reported a suicide attempt. And also, looking at the geographic distribution, the Child Trends Group actually looks at this across states. And I mean, I don't know, and no disrespect to West Virginia, right? But thinking about where are there more draconian anti-LGBTQ affirming legislation, right? And assaults to well-being that are happening at the structural level, and how that may map onto suicide risk for the structurally vulnerable population. And then for transgender youth, right, suicide risk is 4 to 7 times higher compared to their cisgender peers. Youth with disabilities. So in terms of thinking about structural vulnerability and thinking about power and privilege, right? Suicide risk for youth with multiple disabilities is nearly 8 times compared to those youth with no disabilities. And youth with disabilities often do not have centering and discussions around mental health or behavioral health, but they do have mental health needs, and that their increased risk is likely to their elevated experiences of marginalization. So if we sort of apply that lens and framework of structural intersectionalism and think about it from that way, this makes sense. Okay. And then thinking about LGBT youth who report a suicide attempt is highest among youth who identify as more than one race. So again, we're seeing the confluence, right, of multi-ethnicity plus sexual minority status. Okay. And then sadly, right, most state suicide prevention plans omit the role of discrimination and youth suicide risk. Now, New York is leading, right, and figuring this out. But really, if we kind of look at some of the state plans, 32 plans describe disparities in suicide by race. And of course, New York is here. Where are we, New York? Oh my God, I see it. New York is here, New Jersey, no, but New York is here. And then 14 of those have plans specifically around thinking about racism. 20 plans omit information around racial disparities. And so this is a missed opportunity, right? Because you can't really talk about, I think in this day and time, suicide without talking about the racialized and discrimination patterns. And you need a plan to really address the disparities as well as to address racism. Even more concerning is state and territorial plans addressing LGBTQ youth, right? So we have less states who have specific plans around this. And then for disabilities, even less, right? So thinking about structural intersectionalism and how that, maps onto policies, procedures, practices, and programs, and what we can as providers do to sort of spotlight that. So this is probably, the sort of greatest area for growth. I want to pause and take some questions because I think I'm getting towards the end of my time. Is that correct?
Dr. Bath, you have about 20 minutes.
Oh, good. Okay.
Keep going, and then we'll have 15 minutes for Q&A.
Okay, 20 full minutes to keep talking.
Yeah, take about 15 to 17 full minutes to keep talking.
Okay, perfect. Okay, all right. So let's look at pre-adolescent children. So we know hopefully you guys are familiar with youth ages 5 to 12 having increased suicide risk, but this study actually looked at the ABCD, which is a really large data set, stands for the Adolescent Brain Cognitive Development Study, and it really sort of wanted to start teasing out the links between discrimination, stress, and suicidality. And this study is really important because it's enrolled, 11,000 over 11,000 children. It's following them across the lifespan. And so we need to make more inroads in understanding how discrimination, stress impacts suicidal behavior. And surprise, surprise, right? Black youth who reported more discrimination had higher suicidality rates than non-Black youth. And that, high racial ethnic discrimination experiences was significantly associated for suicidality. And so this is very key. And it's not just in Black youth, but also in Latinx youth. And so we need to really start thinking about how to address this and what sort of resilience building strategies there exist. Really sort of Black participants experience significantly higher rates of all 4 types of discrimination, right? So not only is discrimination associated with suicidality, but the range and experiences of discrimination and the volume of discrimination also matters, okay? So compared to non-Hispanic participants, Hispanic participants also experience higher rates of discrimination toward non-US born individuals and weight-based discrimination. So discrimination, again, if we think about the sort of axes of power and privilege, having, disability status, weight status, skin tone, all of those things matter, and there are ways in which those can overlap with discrimination. So what's really interesting is like weight discrimination is really high in terms of conferring risk for suicide. So Black youth reported more discrimination, higher suicidality than non-Black youth. And really sort of thinking about adverse youth outcomes, right? And how discrimination not only sort of impacts well-being in the moment, but this sort of anticipation of being worried that you're going to have discrimination, and how that can lead to both depression and suicidal behavior. And so not only is there anticipated a concern, but there's also what we call vicarious concern. So when I gave the example earlier of folks, seeing images of, people of color being brutalized on the media, or just being labeled, and characterized as being dangerous, aggressive, thugs, etc., that has that inflicts harm. And so this sort of vicarious racial ethnic discrimination does impact well-being. So it's both on the personal, the vicarious, and just anticipating that type of harm. So how do we sort of unpack this a little bit more? So anticipated racism and discrimination is like outward expressions of racial animosity, police killings of unarmed persons of color. It's estimated that 1 in every 1,000 Black men can expect to be killed by police in their lifetime, or Black, males, like cisgender males. That's really high. Right. And so knowing that, and probably most people don't know that statistic, but they are experiencing the structural violence of law enforcement in their communities, having that sense of, constant threat, antagonism towards, immigrant communities as well, can breed this sort of anxiety. And so this state, right, of anticipated discrimination, which if we think back to Arlene Geronimus's work and weathering, right, this high sort of levels of threat perception, it's breaking us down at the microcellular level, but it's also just causing anxiety as well. And then thinking about vicarious racism and discrimination. So youth are impacted by their parents, their experiences with racial ethnic discrimination, but also within their communities. So the fact that there's a lot of data that supports that parents' experiences with racial and ethnic discrimination can have indirect effects on child's mental health, as well as their own sort of parenting capacity, is really important. And so why does this happen, right? So there are different hypotheses, but really this sort of, thinking about it from the angle of you're having these experiences over and over again, and they're associated with just different depressive symptoms. We know the links between depression and suicide risk. And then if Latino and Black respondents are having higher levels of discrimination, they're going to be disproportionately exposed to these phenomena. So developmental research really needs to kind of start thinking about discrimination in different ways, right? It's not just one sort of monolithic blob. There's the experience of discrimination, right? But just also the anticipatory threat, as well as vicarious discrimination. So part of, I think, if we think about the sort of new world order and how we think about the clinical encounter, is to also assess for parental or caregiver experiences of racial ethnic discrimination, as well as experience versus anticipated in the youth we serve. Okay. So currently we have a lack of suicide prevention strategies that really think about disparities in their full intersectional reality, right? And so we're not necessarily addressing them like from risk, protective factors, and access to services for youth of color. And so one recent paper that came out in June of 2022, actually proposed the structural racism and suicide preventions framework to really think about youth suicide prevention and really for youth of color, right? So thinking about these sort of three domains of schools, mental health services, and the intersection between crisis care and law enforcement. And so really recognizing sort of structural racism as the driver, right, of disadvantage, and the disadvantage is far reaching, but really how can we think about how to address that across the different levers? So really we have racialized gaps in terms of mental health treatment. And so if we're going to make inroads in suicide prevention, we have to address the gaps between treatment need and treatment receipt for ethno-racially minoritized youth. So 31% of white children with mental health problems receive mental health services, but only 13% of children from diverse racial and ethnic backgrounds receive mental health. And so that gap alone, right? It should be 100% of children getting services who need them, right? So the gap is problematic for white children, but also for ethno-racially minoritized children. So closing this gap in terms of treatment is going to be essential, but also thinking about how to address that from the provider perspective as well, because providers are key system actors that can make or break someone's access to treatment. And so when providers lack sort of cultural humility and cultural competency training, they're less likely to make the referrals to services. And so that is something that's really critical to address as well. So the gap, in terms of, where is treatment available, we know when we think about zip codes determining health outcomes and we think about structurally where there's more mental health services available, there's less services available in neighborhoods with concentrated poverty, right? But also we can't afford to then have providers enacting bias towards the individual and having differential referral patterns. So both factors are important, so really thinking about lower rates of access to mental health services and delays in access are really something that need to be addressed. And so hopefully with this program, right, we're educating folks to be more attuned to the needs of these populations, and also teaching you all some language around to help cultivate bias resistance. Okay, I'm going to fast forward this slide and this one. So thinking about inequities across different domains. So we talked about service pathways, but really we have a crisis, and part of the crisis is due to lack of just robust behavioral health workforce. So 70% of the counties in the US have no child psychiatrists. I was at a talk in June, and I learned that there's like one child psychiatrist for every 11,000 youth. Now, child psychiatrists, we're actually not the majority. Like most youth who are going to get behavioral health services are not going to get a child psychiatrist, which is another challenge, right? But we really have these huge gaps in accessibility, and they're aggravated by the fact that we don't have a robust workforce. And then how do we define the workforce, right? But this is sort of structured by rural location, right, and income and segregation. And so we really need to think about how to address the location and availability of services, and then who provides them. And so youth of color, when they do get services, if at all, they're going to present with more severe symptoms because they just haven't had access. So they'll often, if they're able to access the provider, they're coming with more severity. And then once they have contact with that system, because it's more severe, they're more likely to receive coercive or punitive responses. Similarly, we have to think about schools, right? So if we think about settings for suicide prevention, one presentation I was at earlier today, a family care doctor was saying that they maybe get an hour and a half with a kid in a given year, right? Whereas schools, kids have an average of 1,000 hours of contact time. So we got to work with schools, right? And we have to make schools be safe and affirming spaces. But for many, children of color, schools are not sanctuaries. They are places where there's, exclusionary discipline. There's law enforcement that leads to, criminalization of youth and color. And we know that BIPOC youth actually receive higher punitive discipline. And when they do have mental health needs or learning problems, that those that contact with law enforcement is actually increased. So rather than getting therapeutic services, they're really getting more punitive disciplinary action. And so we're losing an opportunity to provide meaningful suicide intervention. And then thinking about crisis and law enforcement, just because of the density of law enforcement in certain communities, youth of color are having more contact with them. And then what happens when that contact occurs? Are they getting sent to the hospital, or are they getting having more contact with the carceral system? And so how do we sort of make sure that law enforcement is trained and able to access behavioral health services, that they can be actually part of the armamentarium that connects kid to services as opposed to the carceral system? And so many youth report negative experiences with law enforcement, and it's very dangerous, for many youth of color to have these contacts. But it's also that law enforcement historically have not been part of the mental health apparatus, and will tend to put youth more in detention based settings. So really, if we think about this from sort of a macro system level to an individual level, we need to think about sort of services and access to care, right? We need to think about families, and we need to think about also like places like schools where we can actually activate some really important levers, and thinking sort of structurally what sort of policies and procedures are in place to optimize those settings, right? So in California, I know in Los Angeles in particular, we have a really robust partnership with our public mental health, Department of Mental Health, and school districts. And there's several wellness centers where that are co-located within schools, but that's not the case, right? For most jurisdictions, they don't have a sort of robust school-based mental health program. And even in LA County, I would say that even though we have made a lot of inroads, I don't know if it's sufficient levels of providers or programming to really meet the needs of youth, right? And really, how does racism aggravate all of these access points and really disrupts that? And so thinking about, certain neighborhoods where there's sort of less behavioral health providers, and they're less likely to be in certain school districts. Okay, so thinking about this, I think that they had a really nice chart in really thinking about addressing cultural racism, institutional racism, and interpersonal racism across these different domains. So really understanding how racism in these spaces results in health inequities, and then also applying structural interventions to address them. So thinking about cultural racism, right? Negative attitudes and beliefs towards racially and ethnically minoritized populations are embedded in the societal values and practices. So in states with high levels of racism, that impacts the efficacy of psychotherapy for Black youth, right? In schools with higher cultural racism, there's greater disparities in terms of disciplinary actions that disadvantage Black youth and put them in the carceral setting. In examples in crisis care, there's over-reliance on coercive, emergency, acute settings as opposed to outpatient settings, right? And so what can we do is really think about, in terms of structural intervention across those different domains, really addressing macro level policies that promote racial and economic justice. And so you can go along these different ways and think about different just ways to disrupt these cycles. So youth are really embedded in these multiple ecological contexts, in which these adverse conditions occur. And so really thinking about ways to innovate across these ecological contexts is really the sort of take home of that article. Okay, so we have to understand how structural racism impacts adolescent mental health. Otherwise, we will not get equity. And so this study really looked at neighborhood privilege measured by concentration of extremes, and really found that, in communities where there's less privilege, more deprivation, right? There's higher levels of depressive symptoms and suicidality. And then, of course, neighborhoods and racialization of neighborhoods due to segregation and legacy of segregation in our communities map onto each other. And so I think the take home of this is understanding that we have to work also at addressing concentrated poverty. We have to sort of work and think about neighborhood factors, community violence, gun violence. Those things matter in terms of addressing health equity and mental health equity in particular, because structural forces around neighborhoods are conferring vulnerability to suicide. And so thinking about sort of racial privilege, economic privilege, and the combination, if you have sort of lower racial and economic privilege, you're going to have greater risk of depression and suicidality. And so really sort of capturing both and addressing both and using our position to do so. Okay, I'm going to skip through this slide. I want to go here and talk a little bit about concentrated poverty before taking questions. So poverty is structured and is really concentrated. People who experience the most concentrated poverty also are American Indian, Alaskan Native, Black, and Latino communities. And so this is a huge barrier to mental health treatment, and they're inextricably tied. So we can't really think about concentrated poverty without thinking about racism, and we can't really address, we have to address these gaps together. And so one of the things is really dismantling community systems where we have less access to mental health care. And so really increasing, sort of addressing the scarcity and thinking geographically about how to embed resources. I know that this is a group of New York City providers, and probably, I used to live in New York City. I trained there at NYU, going borough to borough, right? There's different density of services, let's say in Manhattan versus Staten Island versus parts of Queens, right? So how can we sort of think about the distribution of resources and really use an informed lens and thinking about where there's higher social vulnerability index, right? And how can we plant services there? Because we are already burdened by a lack of providers, right? We don't have enough providers, but we can't doubly compound the lack of provider challenge by putting less density of providers in areas that have higher need. So I know that we're not optimized for video, so I'm not going to play this video, but it really talks about the crisis for Asian American individuals, and that they've been sort of eclipsed from the discussion around the racialization and racism and suicide. And just to include this, as part of how we address it, particularly we've seen a rise in anti-API crimes. And so understanding sort of structural violence and historical trauma that's been exerted on this community as well, and also understanding cultural stigma that is a barrier, but the structural barriers are far greater and aggravate cultural stigma, right? And so we can't sort of delink the sort of structural forces that make different communities have certain types of vulnerabilities. And also typically people do refer to the AAPI community as a sort of monolith when there's so much heterogeneity, and it's not just one group with one sort of, socioeconomic status and background. And so really sort of starting to make our understanding of culture more granulated to really reflect the reality of the populations we serve. And really there's been a sort of pandemic bump to sort of how people have been experiencing racism and discrimination related harms, particularly to the AAPI community. And so the sort of sense of safety, right? And this notion of vicarious discrimination, right? And then the community level impacts well-being and impacts well-being as it relates to mental health and also to suicide. Okay. And this is really particularly true for adolescents and young adults. All right. I'm going to go to so what do I want folks to do and learn more about is actually assessing for discrimination. These are two examples, but there's other assessment tools that you can use to assess for discrimination, but we need to sort of embed this in our practice. If we recognize that racism is a public health threat, we see how racism, affects your cells, your brain, your body. Why aren't we really assessing for the impact of racism and discrimination, and also like with caregivers, and using a sort of structural formulation to address and understand how to sort of innovate in those areas, and really having providers develop more comfortable fluency and literacy around these topics. It's really hard for some providers to ask these questions, so use a scale, right? But really developing that comfortability, because we see that racism is really, and discrimination is really everywhere. I'm going to, you guys got briefly introduced to Dr. Jocelyn Meza, my colleague, partner in crime, but she's going to be doing our next webinar on October 17th and looking at risk and protective factors for self-injurious thoughts and behaviors. And we're really going to look also at social cultural risk and protective factors, and going to focus specifically on youth who are involved in the juvenile legal and child welfare systems who also have high rates of suicide and self-injury. I will transition to questions and also ask you, while the questions are coming in, to sort of scan this QR code or click on it in the chat. I think someone's going to put it there to really give us feedback on what we did right, what we could do better. And so we can really, meet the needs of you guys going forward. Thank you.
Great. Thank you so much, Dr. Beth. You're getting a lot of love in the chat. People are thanking you for your work and for everything that you do. And people are also wanting for us to share the slides, which will be shared after the webinar. There was a comment about Ila Hernandez mentioned how she is working on getting more services in the schools for newcomer Latinx youth. And there was actually a question from an attendee, and I'll read it to you. So racism and mental health intersect and shine a light on the disparities in society of youth of color. Should more attention and effort be focused in the schools? What are your thoughts?
Absolutely, yes. And Jocelyn and I just wrote a paper to sort of highlight the importance of racial pride affirming interventions and racial ethnic socializations and schools. When I heard that stat about contact hours, 1,000 contact hours that the schools have versus, the pediatrician, maybe they're seeing, maybe at most, let's say generously, because your kid gets sick, they have an ear infection. Okay, maybe they'll have like 4 contact hours, but what we need schools to be key partners in wellness, right? And most wellness and mental health well-being occurs outside of the clinical encounter. So all the time, it needs to, right? We need to sort of think about prevention, and schools are key for prevention and for service delivery. But how can we make sure that they're delivering services in a culturally informed way, and what sort of tools do they have? So there's some work that's actually data from the 70s showing that when teachers learn and can impart racial pride affirming, you know, approaches, right, that helps youth well-being, it helps with educational attainment, it helps with sense of self-esteem. And so how do we increase educator literacy around those concepts, reduce their bias? Because we also know that teacher bias contributes to racialized gaps in terms of really, you know, being referred for ADHD assessment. There's a huge Black, white, Latino, white ADHD diagnosis gap, but that starts in the schools, like many places where these things are identified in the schools. So I think schools are key. One of my colleagues, Dr. Cheryl Kataoka, does a lot of work historically for several decades, same with Dr. Audra Langley, in sort of thinking about school-based mental health, making those systems be more trauma-informed, increasing partnerships between school districts and you know, community mental health organizations and public mental health serving organizations, and really sort of embedding those. And also it helps reduce stigma, right? So
yeah,
the nation platter.
yeah, and I think one of the things that you've discussed in your work and as a forensic psychiatrist is that the school can disrupt that pipeline from school to prison, where we know kids have the highest risk for suicide.
Yes, and I mean, so schools are sort of vital in either pushing kids down one path or the other, right? And so, you know, how kids are labeled, how they're sort of seen. And we know that in certain communities, especially those experiencing concentrated poverty, those communities are more likely to have law enforcement in schools. But it'd be much better if a kid is struggling to have contact with the teacher as the caring contact. I mean, no disrespect to law enforcement, but their toolkit, they've been hardwired typically to use a different set of tools, right? More punishment based and less therapeutic. So I would say remake all systems, right? Get law enforcement to be more therapeutic and equip, like maybe keep them out of schools as much as possible, but also increase educators' capacity to really be trauma informed, strength based, and racial affirming.
All right, you have some more questions coming in. So I'll ask the last two that are here. What can be done to better address the mental health needs of BIPOC children and teens in a holistic and culturally sensitive manner?
Wow, I mean, so many, but I think sort of thinking about racial pride affirming spaces and cultivating those. So there's literature that supports like youth participating in social justice movements and activism, you know, affinity groups, youth sort of learning about their brain and understanding, you know, developing mental health literacy. So there's some clubs out there, whether it's from NAMI, Mental Health America, Bring Change to Mind, Youth Mental Health Association. There's different groups that actually can help youth educate themselves and sort of have sort of student-led initiatives to decrease that stigma. So I would say that those would be sort of key things, but not every school district has those type of clubs, right? So again, structurally, thinking about resource allocation, but we do need affinity spaces for youth to learn about their, you know, brain and their development, and also to be able to talk safely about any challenges they may have and develop the language to do so with, you know, structure and caring adults in community, and also parent education, right? So if we think about, you know, where are their parent resources for learning about, you know, how can schools really be that resource or provide that resource? Because many times community-based organizations are pretty under-resourced. So how can we think about ways to bring in caregivers in that conversation?
Right. And this question was by Kenya Park. So Kenya, if you stay tuned for webinar number 3, that whole webinar is going to be focused on how can we make suicide prevention more culturally responsive to different groups. Dr. Bath, you're getting a lot of love from people. Joseph Washington is saying, thank you, Dr. Bath. This was very insightful information and broadened my awareness on suicidality in young persons and the role that the systemic racism plays on suicide attempts. So a lot of people thanking you for your work. And then a shout out by Laura, where she's giving people a shout out. Laura wants to give a shout out to Life is Precious, an after school program for Latinx teen girls who have engaged in suicidal behavior, and it's located in Bronx. So thank you, Laura, for sharing that. Yeah, we're gonna save that link so that we can take a look at it. Okay, so I don't know if we have time for one more question that Jessica added to the chat, and this will be the last question we'll be taking in. And the question is, do you think that racism and discrimination is going to increase in New York due to the large amount of immigrants that just arrived? How are we supposed to assess their mental health needs? Great question.
Wow. Yeah, there was a New York Times article about, I think it was what, 10,000 youth. I think education, we need to also have more culturally, linguistically appropriate services. We need to activate community health workers to sort of educate providers, because probably our educators and our behavioral health workforce are not multilingual enough to meet the needs, and to also be trauma informed. We need to understand sort of the legacy of racism as it pertains to immigration specifically. I think that there's like a lack of just general awareness of policies and procedures that have put harm on migrating peoples, and so many different groups in particular. And so I think sort of that could be one of our behavioral seminars, is sort of talking about those processes, because I don't really think I've been, formally educated on that. And there's definitely been an influx as well. And so, creating sort of capacity within our systems to provide care. Right. And so what would that look like? That would be, working with communities, working with advocates and attorneys, right, who are going to be serving those folks. Many times, at least in LA, we have a partnership where we provide asylum evaluations and connection to mental health services, because the needs are multimodal. And so making sure that our systems are equipped. But yes, do I think that there's going to be a rise in racism? Yeah, I mean, we always see that. There's been a rise in hate crimes, sadly, across the country. Post-COVID, it's been growing against various groups, from Latinx, API, Black, trans. I mean,
xenophobia is real, Jessica. Jessica was the person that asked this.
Sadly, equal opportunity.
Well, we thank you for your wealth of knowledge and for really centering this critical conversation that some people in the chat were noting that is often avoided. So we appreciate you kind of really opening up that space to talk about it in the context of suicide. And I just want to invite everyone to our upcoming webinar. So this is just the start of the discussion. This is a 4-part series. We're going to be talking about, for example, how immigration and acculturation stress impacts suicide, and how do we address it from a clinical perspective. So please stay tuned for the upcoming webinars and complete the Qualtrics survey so that we can continue informing this important work. Thank you again, Dr. Bath. We are so privileged to have you.
Thank you. And thanks everyone on the team. Thank you, audience members.
Bye, everyone.
Thank you.